Very good morning. I bring greetings from the Indian Society of Gastroenterology. A very warm welcome to another session of ISG Masterclass. This is Series 4. I am Matthew Philip, the Secretary General of Indian Society of Gastroenterology. The theme of this series is Challenges in Day-to-Day Practice in Gastroenterology. We have very eminent speakers and experienced moderators for these sessions. I acknowledge the efforts taken by the past president and the president-elect, as well as all the governing council members who took active role in charting of this program. I especially thank Sudipta Chowdhury as well as Bhaskar Nandi for taking special interest in charting out this schedule of topics. The previous sessions were well attended with meaningful interaction with the faculty. I would like to inform some housekeeping announcements for the participants. Please post your questions and also try to answer the poll questions. We'll try to answer all the questions which you raise, and it will be discussed with the panel of experts there. Now, may I request the president of IST, Professor Sandeep Dijavan, to take over the proceedings and introduce the moderators. Thank you so much.
Thank you, Dr. Matthew. I bring greetings from the Governing Council of Indian Society of Gastroenterology. As has been told by Dr. Matthew, it is a Masterclass Series 4, and the name is Challenges in Day-to-Day Gastroenterology Practices. Today, we have a talk on biologics in IBD with one of the best in the world by Dr. Vineet Ahuja. We have best of the moderators who are working in the field of IBD from India. Dr. Devendra Desai, who is a consultant gastroenterologist at PD Hinduja National Hospital and Medical Research Center, Mumbai. And with him, we have Dr. Rupa Banerjee. She is a senior consultant at AIG Institute, Hyderabad. Both of these have best of the knowledge and insight into the subject. Now I'll hand over the proceedings to Devendra and Rupa for the session.
So I have the pleasure of introducing Professor Vineet Ahuja, who is today's speaker, and we cannot get any better speaker and any topic in gastroenterology. So Professor Ahuja is professor in the Department of Gastroenterology at All India Institute of Medical Sciences, and he is also Associate Dean Research of AIIMS. Just to add to this, he is member of IOIBD and several other committees. So I would request my co-moderator, Dr. Rupa Banerjee, to start the proceeding of today's talk.
Thank you, Dr. Devendra. I think, yes, I think from Dr. Vineet, we can all learn a lot. And the topic today is something we really face in problem in day-to-day practice. We know that biologics have revolutionized the management of IBD, both ulcerative colitis and Crohn's disease. But in India now, we have multiple choices. So we need to understand which biologic for whom, which should be the first line drug, when should we switch, what should we switch to, and what we should be careful about. And to address this, as Dr. Devendra mentioned, I think Dr. Vineet is the best person. Over to you, Vineet.
Okay, thank you so much, Rupa. I'll just share my slides. Okay. So first of all, I'd like to thank Professor Sandeep Dijavan, President, Indian Society of Gastroenterology, Dr. Matthew Philip, Honorary Secretary, Indian Society of Gastroenterology, for chalking out an excellent educational activity. And I have excellent moderators today, so I hope that we have some beautiful discussion at the end. I'll be talking about biologics and IBD, how to choose the right one for the right patient. Now, this has been absolutely a momentous week for India. There is no doubt about that. It has been a week of great pride. It has been a week of celebration, and it has been a week of great hope. This is how we started maybe around 60, 70 years back. This is a Thumba range. That is how the first rocket was carried on a bicycle. And today we have Pragyan, which walked on the moon. That is how things started, and that's where we are going right now. Similarly, in the field of IBD, we have a lot of hope, glimmer and rays of hope. We started with infliximab way back, but within 20 years, look at the plethora of agents which are available, agents which are marking out different mechanisms of action, agents which can work at different pathways. And not only that, these agents are available globally, but if you look at India today, we find that many of these options are available in India. We find that, yes, infliximab was introduced out here maybe 15, 20 years back. We have infliximab biosimilars, we have adalimumab biosimilars, we have vedolizumab, tofacitinib, ustekinumab is available. Surgery remains an excellent option and has always been there. There are only 2 or 3 options which are not available in the country today, and I'm pretty sure that within next 6 months to 1 year, these should also be available. These include options like upadacitinib, the P19 IL-23 inhibitors is a new class of agents which has come up, and chief among them is risankizumab, and then we have another oral small molecule that is ozanimod. So today I'm going to discuss 3 things. I thought that I would plan the talk in divide into 3 parts. One is general principles, because I believe that if you know the general principles, then it is much easy for you to navigate through various clinical scenarios. Because if you don't know the general principles, then often you are not able to take critical decisions. Then we'll talk about subsequently about clinical scenarios. Clinical scenarios, obviously, we'll talk about what happens in various subsets of Crohn's disease, ulcerative colitis, the elderly, the young, etc., which should be the first-line therapy, whether the newer agents can be the first-line therapy or they have to be the second-line therapy. And then we'll have certain situational issues, which I'll call the rapid-fire round. Rapid-fire round means that these are situations which arise and suddenly you need an answer. These are things like if a patient develops, let us say, drug-induced lupus. If a patient comes with malignancy, you have to give a biological. If a patient has a hepatic disease, you have to give a biological. What do you do? So that is how I plan. So first, I'm going to talk about general principles. We have 3 terms: small molecule, biological molecule, monoclonal antibody. When we talk about biologicals, it essentially means that they have been derived from living organisms, that is cell cultures, etc. They are very complex structures, they have high molecular weight, and monoclonal antibody is a kind of biological. All biologicals are not monoclonal antibodies, but monoclonal antibody is something which is a biological. And when we talk about agents which are available in IBD, most of them are monoclonal antibodies. Another class of drugs which has come up is small molecules. That is the regular hydrocarbons, which have low molecular weight and which have a well-defined structure. So first, let us talk about what are the agents which are available. And for that, we need to find out where do they act. Why do we need to find that out? Because if you subsequently want to change agents or if you want to combine agents, it is very necessary that you have a basic idea about the mechanisms of action. When we talk about IBD pathogenesis, these are the main players. Most of the action takes place around the epithelium cell, and the factors which cause IBD would be a microbial flora dysbiosis, a genetic susceptibility, environmental factors, and aberrant immune responses. You will be amazed to know that whatever armamentarium we have for treating IBD, most of it is on aberrant immune responses, that how it changes the immune responses. Right now, I don't think there is any therapy which is available in a way which is approved therapy, I would say, which is there for any other, which acts on any other hub. All the therapies act on one hub, and that is an aberrant immune response. The major cytokine has been TNF-alpha, which is produced by macrophages, which is produced by dendritic cells, which is produced by T cells, as well as the B cells. So obviously, it makes a lot of sense in blocking TNF-alpha. So we have infliximab and adalimumab, which are the classical anti-TNF inhibitors, which eliminate as well as neutralize TNF-alpha and interrupt the inflammatory response. The second kind of cytokine blockade occurs when we attack the receptors. IL-12 is a heterodimeric cytokine which has 2 units, P40 and P35. It is a major cytokine for Th1. IL-23 is again heterodimeric, which again has 2 subunits, P40 and P19, and it is a major cytokine for Th17 pathway. Both Th1 and Th17 pathway play a very important role in pathogenesis of both ulcerative colitis as well as Crohn's disease. And what we find out here is that P40 unit is subcommon. So if you have a monoclonal antibody that is ustekinumab, which blocks P40, it will be blocking IL-12, subsequently blocking Th1 pathway. It will be blocking IL-23 and subsequently blocking the Th17 pathway. Thereafter, it was seen that if you block only P90, IL-23 had two subunits, P40 and P19. If you block P19, that also mitigates inflammatory response to a large extent. And so have come up two agents which are known as risankizumab and mirikizumab. Risankizumab has already been approved by FDA for Crohn's disease, and mirikizumab is undergoing phase 3 trials. The next set of agents is that you attack the soldiers. Till now, we were attacking all the cytokines. That is the emanation which is lying out there, which causes inflammation. But if you prevent the soldiers from reaching the site of inflammation, that class of drugs is known as lymphocyte trafficking inhibitor. Lymphocytes, when they're activated, they go through the blood vessels. Through blood vessels, they have to go through the site of inflammation, which is the lamina propria. And to get them to go through the endothelial cell wall, there's an interaction whereby alpha-4 beta-7, which is a receptor on the lymphocyte, interacts with MAdCAM1, which is an endothelial cell receptor. This interaction, if blocked by vedolizumab, which is an alpha-4 beta-7 inhibitor, does not let the lymphocytes from reaching the site of inflammation, where they are subsequently going to cause war, I would say. So this is a lymphocyte trafficking inhibitor. There is another kind of lymphocyte trafficking inhibitor which is available. That is one which prevents lymphocytes from leaving the lymph nodes. All the lymphocytes, they are initially naive. They have to go to a lymph node where they have to get activated. And once activation occurs, there's a gradient which permits them to reach the site of inflammation. That gradient is through a S1P receptor, which is there on the lymphocyte wall. So what ozanimod is going to do, it is going to modulate the S1P receptor on the lymphocyte. As a result, the lymphocytes are not able to find their way to the site of inflammation. They are not able to enter the circulation at all. So this is another way by which soldiers do not reach the site of war, and as a result, you can mitigate the responses which are occurring out there. So till now, we have talked about essentially drugs which have been acting extracellularly. We talked about TNF inhibitors. We talked about IL-12, IL-23, that is ustekinumab inhibitors. We have talked about anti-integrin inhibitors, which are essentially all extracellular. There are certain drugs which act within the cell. In other words, they attack the ammunition depots. Cells are ammunition depots like. So these are known as what are known as JAK inhibitors. The positive point of JAK inhibitors is that they can attack multiple cytokines. So they're not only acting only on TNF alpha, they're not acting only on IL-12 or IL-23, they can act on multiple cytokines. What they do is JAK inhibitor, what it does is it blocks the cell signaling pathway. As a result, any cytokine, when it gets attached to the cell membrane, thereafter, if it has go inside the nucleus, that kind of pathway gets blocked. As a result, the cytokine is not able to initiate the transcriptional activity. And classical prototype for that is tofacitinib. So tofacitinib is something which blocks JAK1 receptor, JAK2 receptor, and type 2 receptors. It's a pan-JAK inhibitor. Another agent which has come up is upadacitinib. That is very selective. It acts only on JAK1 inhibitor. So the advantage is that maybe not only it provides a good action, but at the same time, possibly it decreases the number of side effects. So what we find is that there are two classes of drugs which have come up. Earlier, we had monoclonal antibodies or the classical biologicals, and now we have oral small molecules which have come up, which are like tofacitinib, upadacitinib, ozanimod. The fundamental difference we need to understand between them is that oral small molecules are hydrocarbons, easy to prepare. They can be kept at room temperature. So as a result, the cost is very low, which is very good for the patients. Whereas biologicals are complex proteins, require refrigeration. The cost is very high to prepare them. Secondly, the biologicals require intravenous or subcutaneous route. So the onset of action, particularly if it is subcutaneous, would be slow. Whereas oral small molecules, they have a very fast onset of action. So patient acceptability as well as patient comfort, both ways it is better. The only issue with oral small molecules is since they have an intracellular site, many sites of action. So as a result, the adverse events are more generalized. Their drug-drug interactions are much more frequent. And the metabolism is also dictated by hepatic pathways as well as renal pathways. So when we look at it, we know why oral small molecules act very fast. So if you want somewhere where you want to decrease inflammation at a much faster rate, oral small molecules would fit the bill. Second thing, despite all these agents we find that there is something which is known as therapeutic ceiling. That is, most of these advanced treatments, they report a clinical remission rate at 1 year of 30 to 50% only. They do not go beyond that. The clinical responses may be 60%, 65%, but remission rates are to the tune of 30 to 50%. This is very surprising. Even though they are acting at different pathways, yet they have one uniformity. That uniformity is the therapeutic ceiling. They do not go beyond a certain limit. Why is it so? Because all of them act on the immune system, and the immune system is very redundant. So it's not that there's only one pathway which is going. There are multiple pathways to reach to a point, and if you block one pathway, obviously after a certain period of time, the inflammation can go through, reroute itself through another pathway, and blocking one pathway is not going to help. So much so that, as I told you, there's a lot of hope. There's a glimmer of hope, ray of hope. You have so many agents which are available. But if I look at one line, the summary line from a review article in NEJM, which just came up just 2 years back, the first thing which they write in summary is currently available therapies cannot cure IBD. And that is a fact. Most of the time, you're controlling inflammation. You're not able to cure it. And that is one point which we have to understand when we play with biologicals. In the sense that whenever we are giving biologicals, we can only control inflammation, will not end up curing the disease. In a way, like, yes, Pragyan, we have landed on the moon. Pragyan rover is moving on the moon's surface. It has landed on the south pole of moon, but it has not found water as yet. And the same is the situation with IBD. We have everything going for it, but at the same time, we have not found that magic bullet or the magic cure by which you can ameliorate the disease. Next general principle, when to give advanced therapy. Now, you know that I have changed my term from biologicals and oral small molecules to advanced therapy. This is a new terminology now. Whenever we are talking of drugs which are not steroids or which are not azathioprine or methotrexate. In other words, when we're talking about giving biologicals or oral small molecules, we call it advanced therapy. The indications are classical. For ulcerative colitis, lack of efficacy of treatment using steroids or immunomodulators, steroid-dependent disease, steroid refractory disease, and also refractory pouchitis, chronic refractory pouchitis. Crohn's disease, again, lack of efficacy of classical treatment using steroids or immunomodulators, whether it is lack of efficacy or intolerance, any of them be there. But in Crohn's disease, there's one difference as compared to ulcerative colitis. You can have top-down therapy. It's not a stepped-up therapy all the time. Particularly in aggressive Crohn's disease, you can straight away start with advanced therapy. Post-operative recurrence is another indication for advanced therapy in Crohn's disease. And now, most importantly, when not to give. The classical indications or contraindications would remain active infection, just forget about it till you have treated the infection. Untreated tuberculosis, do not give. Active malignancy, also probably a contraindication, but I put a query mark about it, and I will discuss it subsequently. Yes, you would be very, very cagey about giving it in active malignancy. Then there are certain contraindications which are drug-specific. Anti-TNFs, do not give if there's demyelinating disease, multiple sclerosis. Parkinson's, you can give. Congestive cardiac failure, do not give. Tofacitinib, do not give if there is any history of thromboembolism. Elderly with coronary artery disease, severe, no, don't think about it. Child C cirrhotic, chronic renal failure, one would exercise a lot of caution. Why? Because it is metabolized through hepatic and renal pathways. Vedolizumab and ustekinumab is something where you find that there is no definite class-specific or drug-specific contraindication. The main contraindications remain, which are general, that is active infection and untreated tuberculosis. Next important thing is how to screen for them. This is again very important because, as I said, you're not curing IBD. You're not able to kill IBD for sure. But do not end up causing harm to the patient by being very exuberant about giving biologicals or oral small molecules or advanced therapy, as we call them, without screening. What kind of screens you would like to do? Latent tuberculosis, Montu, IGRA, chest imaging. Chest imaging, we'll discuss further, whether it is a chest X-ray or a CT. HBV, HBsAg, and we do an anti-HBs instead of doing a total anti-HBC, because if anti-HBs is positive, particularly for young patients, most of them have been vaccinated earlier. So if anti-HBs is positive, then you don't need to do anti-HBC, which is a lot more expensive. HCV, HIV serology, varicella serology, look for it. Vaccination needs to be given if you can plan it. Most of the times we talk about it, but we are not able to give it, because often by the time the patient comes to, the patient may be sick and there will be no window at all to give vaccination, because live vaccine you'll not be able to give. If you're going to start advanced therapy, killed vaccines you may give, but they may not be that effective. But if you get a window, then do vaccinate the patients, and the vaccines to be given are HIV, HPV, influenza, pneumococcal, varicella serology. If negative, give the live vaccine. That's the only live vaccine out here 2 months before the biologicals. If you're planning tofacitinib therapy, you should give recombinant herpes zoster vaccine that has been launched in India. It was launched around 3 months back. 2 doses are there, 0 to 2 months, and is to be given irrespective of previous history of zoster or varicella infection. It's not if a patient has had zoster, you'll say, okay, fine, I won't give the herpes zoster vaccine because the patient may have formed antibodies. No, it doesn't work like this. The CDC recommendations are very clear that irrespective of previous episode of zoster or varicella, you would like to vaccinate the patient. Then very importantly, you have to screen for affordability status, because that will let you know how long you'll be able to give patient the biologicals, whether the patient has insurance, it's a government supported thing, or out of pocket. Very important. Then another set of facts which you would keep in mind, because that will again help you to juggle the advanced therapy, juggle through when you're going to sequence the advanced therapy. Infliximab, half-life is 8 to 12 days with a washout time of 4 weeks. Adalimumab, half-life is more, 10 to 20 days, washout time of 4 weeks. Vedolizumab, half-life of 25 days with a washout time of 11 weeks. Ustekinumab, half-life of 19 days. So what does it tell you? That in general, infliximab would act much faster than vedolizumab or ustekinumab. Vedolizumab is a slow-acting biological. That is what it tells you out here. But when we talk about oral small molecules, they have a much faster onset of action. Tofacitinib has a half-life of 6 to 8 hours. Upadacitinib has a half-life of 8 to 14 hours. So possibly there's not much relevance of washout time in clinical practice today. Earlier, there's a lot of emphasis given to it, but I don't think there's a lot of relevance has come out. But what is very important is the half-life, because if a patient is going for surgery, then tofacitinib you can stop just 3 days before. Whereas biologicals, you may like to give an interval of 15 days or 20 days. Another thing is dosing. You need to dose them very correctly if you want to get the best response. This may look like a very mundane slide, but as I told you, if you want to extract the best response, if you want to get the best success rates, then each of these factors are very, very important, because if you make a mistake in any one of these factors, if there's an error in any of these issues, then the response may not be that good. Infliximab, the dose is 5 milligram per kg, as all of you know. Induction dose 0 to 6 weeks, and then every 8 weeks. Pediatric also remains 5 milligram per kg. Adalimumab is 160 milligrams subcutaneous week 0 and 80 milligrams every 2 weeks. If a patient is less than 40 kgs, then you half the dose. The induction dose becomes 80 milligram. The maintenance dose becomes 20 milligram. Vedolizumab, 300 milligrams every 8 weeks. That is a maintenance dose. But in pediatric cases, you will give 5 milligram per kg. Ustekinumab is weight-based, like 55. The induction dosing is 260, 390, 520, depending upon the weight. And thereafter, the maintenance is 90 milligrams every 8 weeks. Most of the data is not there for 12 weeks, even though it is most of the company sponsors would say that it is can be given 12 weeks, you can decrease the cost and all, but majority of the data does not favor 12 weeks. Most of the data favors a 8-week maintenance dose. You can switch down to a 12-week dose, provided you have induced the patient, maintained the patient, and the patient is doing well. Then that is a kind of de-escalation strategy you can apply. Pediatric dosing is 2 milligram per kg. Tofacitinib, 10 milligram twice a day for 8 weeks and 5 milligram twice a day thereafter. Pediatric is half the dose. Pre-medications. Pre-medications, should you give or should you not give? It seems for infliximab, most of the people do give antihistamine or a shot of hydrocortisone whenever they're giving the infusion. But at the same time, there's a meta-analysis which clearly shows that there is no evidence of, there's no benefit of by giving the pre-medication. Another interesting thing is the infusion timing, because it's important for the patient. They are coming to your hospital every 4 weeks or 8 weeks. Infliximab, first 4 infusions you would like to give over 2 hours, and also observe for 2 hours. Gradually, you decrease the infusion time. You accelerate the infusion timing. 5 infusions, next 5 infusions can be over 1 hour. Subsequent infusions can be over 30 minutes. The patient has more than 1 year on infliximab, doing well. 30-minute infusion is sufficient. No need for 2-hour infusion. Vedolizumab is again a 30-minute infusion. Ustekinumab, the only induction IV requires infusion. Tofacitinib can be given with or without food. It is not something which has to be given after meals. Another very interesting point. Are you going to give adjunct therapy or not? Azathioprine or methotrexate? Well, the classical teaching is give it for infliximab, rest will think. Vedolizumab, ustekinumab, do not give. Is there some change? Yes, there seems to be a change of stance out here. Infliximab, yes, definitely you have to give. There is no doubt about that. You may give a low dose azathioprine and at least for a year. Adalimumab, yes. Again, I think you should give. Most of the data favors that. Give it for 6 months or 1 year. Interestingly, vedolizumab and ustekinumab, also recent data has emerged, which suggests that in cases of Crohn's disease, adding azathioprine to vedolizumab and ustekinumab would help. If there's a loss of response, adding azathioprine would help. Tofacitinib does not require any adjunct therapy. So from where does this data come for vedolizumab and ustekinumab? It comes from 3 sources. One is the pharmacokinetic studies, which did not support giving adjunct therapy in the form of azathioprine or methotrexate to Vedo or ustekinumab. Post-hoc analysis of clinical trials also did not give that kind of signal. So it was thought that you don't need to add immunomodulators. The immunogenicity rates are so low, 2% for ustekinumab, 4% for vedolizumab. But yes, real-world target trial emulation of SONIC and SUCCESS have clearly shown that, especially in patients with Crohn's disease, adding azathioprine to Vedo or ustekinumab may be useful. So we've talked about the general principles. Let's move over to clinical scenarios. With general principles, we are not sure about what agents we are dealing with, what is the proper way to give them, what is the kind of dosing, and what is adjunct therapy. When you position the therapy, this is advanced therapy, as I told you, it's no longer biological. Since there are 2 agents, biological and oral small molecules, we call them advanced therapy. Advanced therapy, the decision path is dependent upon 4 major factors: clinical situation, efficacy, safety, cost. So let's talk about the efficacy first. When we talk about this positioning and efficacy and all, you realize that it is actually like a chessboard game. There's so many variables which are out there. There's so many things which you have to think. It's like a grandmaster's. And let me tell you, you're going to win a lot. There is absolutely no doubt about it, as this young lad has shown us. Also, there could be agonizing defeat in the end at times. So you have to be prepared for that. This is how advanced therapy in IBD works. It's like a chessboard game. There are no head-to-head trials. There are so many agents, but there are no head-to-head trials which are available. So most of the data comes in the form of network meta-analysis. That is a meta-analysis where you have a ranking system. There's a term known as SUCRA. SUCRA is surface under the cumulative ranking curve. It's a numeric presentation of the overall ranking. The higher the number, that means the better the rank. So that is, if it is more than 1, the higher the number, less than 1, the more the value, that tells you that that agent is superior. So let's look at this network meta-analysis, which looks at induction therapy in bio-naive patients with moderate to severe ulcerative colitis. So another term is bio-naive. This is very important because responses are different in patients who have been exposed to biological and the patient has failed that biological versus patients who have never been exposed to a biological. So moderate to severely acute ulcerative colitis, active ulcerative colitis, not acute ulcerative colitis, you find infliximab has the best rank. It ranked highest in bio-naive patients for induction and remission and endoscopic improvement in patients with moderate to severe ulcerative colitis. Now let's go to ulcerative colitis patients who have had prior exposure to TNF antagonists and find out that which agents are going to work the best out here. You have ustekinumab, tofacitinib, vedolizumab, and adalimumab is also there because patients failed infliximab. Ustekinumab and tofacitinib were ranked highest in patients with prior exposure to TNF antagonists for induction of remission and endoscopic improvement, again in moderate to severe ulcerative colitis. So this is data from 2020. Very good papers from Siddharth Singh. Siddharth Singh is incidentally is an AIMS graduate, and he's doing absolutely wonderful work in IBD in US. Now let's go to another meta-analysis which just came out 2 months back. Very interesting. This meta-analysis again looks at patients with ulcerative colitis and again in bio-naive population as well as bio-exposed population. What is interesting about this meta-analysis? Because it adds on 2 to 3 years of data which has been generated after the previous meta-analysis which came up in 2020. Does it change the situation? It changes the situation drastically. Amazing. Upadacitinib, it's a chartbuster. It is the top. Then tofacitinib, then ustekinumab, then Vido and infliximab. What about bioexposed population? Again, upadacitinib is the number one molecule. So what we find is that upadacitinib may be most efficacious therapy for moderately to severely active ulcerative colitis based on intention to treat analysis with similar safety. There were concerns which were raised in an earlier meta-analysis on the safety factor of upadacitinib, but it was seen that no, the safety, if you look at these studies, the safety was also similar across the advanced therapy. So obviously it's a sea change within 3 years. Within 3 years, the whole ranking system went upside down, where we are talking about infliximab on one end, and now suddenly you're talking about oral small molecules. That clearly tells you the shape of things which is going to come. Most diseases, this is going to happen. Oral small molecules are going to replace. This is something like, again, India is going to be at the top. It's like the Indian economy. It was like maybe 10th or somewhere few years back, and gradually it has become fifth already, overtaken UK, and now we'll be third by 2025 or 2026 or something like that. It's absolutely like Indian economy. Let's look at network meta-analysis for Crohn's disease. And what we find out here is that for induction of remission, infliximab plus thiopurine, that is azathioprine, scores the highest, followed by adalimumab, followed by ustekinumab, and then risankizumab and vedolizumab. If you look at, so infliximab and AZA and ADA may be the preferred first-line therapy for induction of clinical remission. When we talk about bioexposed Crohn's disease, again, patients have failed one first-line biological. What happens out there? You find that adalimumab or risankizumab or ustekinumab may be the preferred second-line therapy for induction of clinical remission. What about the safety factor? This is a nice meta-analysis, came up recently this year only, which shows that ustekinumab versus TNF-alpha. In Crohn's disease, clearly there was a much lower risk of infection with ustekinumab. Vedolizumab versus TNF antagonists. Again, a lower risk the signal was seen more in patients with ulcerative colitis, a definitely lower risk of serious infections with vedolizumab. Ustekinumab versus vedolizumab. In Crohn's disease, ustekinumab had a lower risk compared to even vedolizumab, telling us that both vedolizumab and ustekinumab are very safe drugs. We have two agents which are very safe and also efficacious. What about tofacitinib? Is tofacitinib safe? No, there have been a lot of signals about tofacitinib. So tofacitinib, it seems, but at the same time, what it shows is that the risk of infection with tofacitinib is almost similar to the risk of infection with anti-TNF. Whereas with ustekinumab, the risk of infection is definitely low. There is no doubt about that. And so these are the kind of things which you watch out whenever you're giving these biologicals. Like when you're giving the TNF inhibitors, you're watching out for granulomatous infection, that is essentially tuberculosis, or serious infections, which could be viral, bacterial, etc. When you're giving tofacitinib, again, you're looking for serious infections. You're looking for herpes zoster infection, thromboembolisms. Also, DVT is very common with tofacitinib in high doses, particularly in the induction doses. When we are giving TNF inhibitors, again, they may lead to lymphoma. There's a kind of propensity for that, and at the same time, demyelination can also occur. Hyperlipidemia is something which is seen with tofacitinib, but that is transient. So let's go to the chessboard and start building up the table out here. Bio-naive UC induction, what agents can be given? We find that infliximab scored very high in network meta-analysis. Tofa and upadacitinib scored very high in network meta-analysis. Vedolizumab trials have shown that it is efficacious. Ustekinumab is efficacious, but adalimumab is something which can be pushed to the background. If you have these four agents, any one of them can be the first-line therapy, but not adalimumab. And surgery, remember, always remains as a first or second-line therapy. Do not forget surgery. It is very useful for the patients. Many patients benefit from it. Amongst this, the largest data is there for infliximab. Tofacitinib obviously scores in terms of cost. It is just so cost effective and so easy to take, and the patient acceptability is so high that people go for it. Vedolizumab scores in terms of safety. Ustekinumab scores in terms of both safety and efficacy. You would like to maintain with the same drug with which you have got induction. That is a general principle, although you can change. What if there is no response? There is no response to the first line therapy, particularly if you're, let's say we are talking of infliximab, then that means there are two things can be there. One is there can be a primary non-response. You started the drug and the patient never benefited. Second is loss of response. You started the drug, patient benefited. A few months later, there was a loss of response, a few months or a year or two later. The first one is known as primary non-response, that the patient never benefited. It occurs in approximately 20 to 30% of patients. Interestingly, when do you assess primary non-response? When do you? After one dose, after two doses, when do you assess it? So these are the time intervals which have been given. Although most people will just give the induction dosing and feel that if it's 0 to 6 weeks, there is no benefit, then not to do. Essentially, it works out to the same thing. So 14 weeks is the time to assess primary non-response for infliximab. Adalimumab, again, 14 weeks. So roughly it is like when you're giving the fourth dose for infliximab, 3 months for adalimumab, vedolizumab, 14 weeks, ustekinumab, 12 weeks, and tofa is 8 weeks. That is the induction time. There come up two terms which are being used now in the field of IBD, that is switch and swap. Switch is if you switch within the same class, infliximab to adalimumab, or intravenous to subcutaneous. There are subcutaneous preparations available for infliximab outside, so something like that, or an originator to a biosimilar. Swap is when you totally change out of class, that you are giving infliximab, you decided to give vedolizumab. So when there's a primary non-response, it is best to swap. Do not go for switch, right? Whereas if there's a secondary loss of response, patient has benefited to infliximab initially. Now there's a loss of response after a few months or a year. What do? You would like to measure drug levels. If the drug levels are high and the patient is having high inflammatory burden, that means you need to change the drug class. If the drug levels are low, then only do antibody levels. You don't need to do antibody levels if the drug levels are high and obviously the patient is not shown a response. You simply change the class. If the drug levels are low, do antibody levels. If antibody levels are low, drug levels are low, you would like to increase the dose or change the frequency. That is, make it every weekly. If you're giving adalimumab, if you're giving infliximab, every 4 weekly. If antibody levels are high, you can change the drug within the class or out of class. Drug levels, what you would like to monitor is, in a way, this remains a little bit theoretical because in India, we only have infliximab drug levels which are available. Even adalimumab are not available at most places, I think. So the drug levels to be maintained are 5 micrograms for infliximab, 7.5 for adalimumab. Vedolizumab and ustekinumab, you don't need to measure drug levels regularly. But however, if you do measure, these are the cutoffs. And what you would do, whenever there is a low drug level, you would increase the dose for infliximab to 10 milligram per kg, or you would change the dosing pattern, make it 4 weekly. Adalimumab, you would increase the maintenance dose from 40 milligram to 80 milligram every 2 weeks, or make it 40 milligram every week. Vedolizumab, again, increasing the dose to 4 weekly helps if the patient has had a loss of response. Or as I showed you earlier, you can add azathioprine. Ustekinumab, again, increasing the maintenance dose from 8 weekly to 4 weekly helps if there's a loss of response. Secondly, you can again add azathioprine out here. Tofacitinib, if you have given induction period for 8 weeks, the patient has had a partial response, you can increase it to 16 weeks. If the patient is on 5 milligram twice a day maintenance dose, the patient has had a loss of response, you can, for a temporary period of time, increase the dose back to 10 milligram PD. You can capture the responses this way. What about measuring drug levels very frequently, proactively? Instead of waiting for patient to lose a response, why not measure drug level every 2 months or 3 months and accordingly keep on adjusting the drug levels? That is, treat the drug levels rather than the patient. Can you do that? Would it really help? There has been a lot of to and fro data which has been coming on it, but right now, what I would say the acceptable viewpoint is that this is a recent meta-analysis which came up in gastroenterology, which showed that proactive therapeutic drug monitoring does not really help as compared to conventional management when it comes to TNF antagonists in IBD. There was no benefit in clinical remission at 1 year if you did proactive therapeutic drug monitoring. So as of now, unless there are very special cases like fistulizing disease, acute severe ulcerative colitis, you would not like to do proactive drug monitoring. So this is the table which we have built till now. We have talked about PNR to anti-TNF. We have talked about prior response to infliximab, that is loss of response. What happens in patients with ulcerative colitis when they have been given vedolizumab as a first-line therapy and there's a failure of vedolizumab? What do you do? There, the possibilities with you are tofacitinib, infliximab, ustekinumab, and surgery. What about acute severe ulcerative colitis? No response to IV steroids. All these agents are available. And obviously, there are patients who can afford, that is tofacitinib and surgery, and there are patients who can afford these kind of agents. What do? You find that you can use infliximab, you can use cyclosporin, surgery, or tofacitinib. You would not like to use adalimumab, you would not like to use vedolizumab, you would not like to use ustekinumab, simply because, as I told you, the half-lives are 25 days, 19 days. So obviously, the rapidity of response would not be there. Here, half-life is 8 hours. The rapidity of response would be there. But tofacitinib, whenever you're giving, the dose is 10 milligram 3 times a day for 3 days. And thereafter, you give the regular induction dose, 10 milligram twice a day for 2 months. And you always give thromboprophylaxis in this situation. Now comes an interesting point. Can you increase the dose of infliximab, and would it help? Thereas,
Dr. Vineet, we need to take a break when you want to have it.
5 minutes, and then I take a break, 5 minutes or something.
Okay.
So, can you increase the dose of infliximab? Would it help in acute severe ulcerative colitis? Because there's so much of inflammation going on. So there are 3 kinds of regimes which have been proposed. Either give accelerated dose of infliximab, 5 milligram per kg at week 0, 1, and 3. Other is higher dose infliximab. Give 10 milligrams per kg. Many centers do that. 10 milligrams per kg at week 0 and week 1. Or you give the standard dose of infliximab, 5 milligram per kg at week 2, 0, and 2. Which is the best among them? Right now, this question is sub judice. In other words, a very nice study which is going on, and that will only tell us the results. Otherwise, whatever evidence is available is not able to clearly decide whether accelerated dosing of infliximab or higher dose of infliximab is useful. So any one of these you can use right now till we have a definite evidence. Finally, is elderly safety, where safety is a predominant thing. There is absolutely no doubt about that vedolizumab and ustekinumab are the preferred drug therapies. What about pouchitis, chronic refractory pouchitis? Which biological would you like to give? In very recent NEJM paper, which showed that vedolizumab had a 3 times higher response compared to placebo, makes vedolizumab as a drug of choice for chronic refractory pouchitis, because you have the best data available for that in this kind of setting, a randomized controlled trial, followed by infliximab. Tofacitinib can definitely be also used. What about extraintestinal manifestations? Infliximab, adalimumab, tofacitinib, ustekinumab, all of them can be used. What cannot be used? Vedolizumab. Because it has been seen that there's a temporary increased risk for developing arthralgias, which has been observed with vedolizumab. Probably the lymphocytes which are wanting to go to the site of inflammation did not reach there. They went somewhere else. They went to joints or somewhere and caused the inflammation. Pregnancy. We had excellent data for infliximab and adalimumab, and now we have data which is emerging for vedolizumab and ustekinumab. And this systematic review shows that adverse pregnancy outcomes in all patients, pregnancy patients with IBD, was comparable to the general population, irrespective of whether it was given first trimester, second trimester, third trimester. You can give the biologicals up to third trimester. So this is the positioning of therapies for ulcerative colitis, where I have marked in orange is something which can be, any one of them can be used as a first line therapy. So these are the various situations, and depending upon the situations, there are a little bit of changes which you would do. What about Crohn's disease? Again, if you make the chessboard, you find there's a little bit of change out here. Adalimumab jumps up from the last position to almost equivalent position to infliximab. B1 Crohn's disease, induction, maintenance. B2, B3 Crohn's disease, infliximab, adalimumab. Fishalizing Crohn's disease, infliximab, adalimumab. What it does is it replaces Vido. It takes over Vido's position, it jumps up, and Vido goes a little bit back. Inflixi, Ada, ustekinumab, Vido, that remains the sequence, in the sense that you would try to use these agents which are much more efficacious. If there's a non-response to anti-TNF, you would like to use ustekinumab or vedolizumab. If there has been a loss of response to infliximab, then you can use adalimumab, ustekinumab, vedolizumab. If you have used Vido as the first-line therapy, then infliximab, adalimumab, or ustekinumab can be used. Again, for patients who are elderly or safety signal is very important, ustekinumab and vedolizumab remain the drug of choice. Post-operative recurrence, best data is for infliximab and adalimumab. Extraintestinal manifestations, again, vedolizumab would be out and rest of the 3 agents are there. Pregnancy, any 4 of them can be used, right? So if you were to position the therapies, you can also do it in another way. That is, one is look at treatment-related complications. Are they more important? Prior history of serious infection, prior malignancy, advanced stage, multiple comorbidities. Look at all the other factors, risk of disease-related complication. If the patient has a very high inflammatory burden, high structural damage, significant impact on quality of life, that is a major thing which is plaguing the patient. So the patient plays a very important role out here. Is he risk averse or he is more concerned about his disease? If he is more concerned about the disease, the therapy would be different. If he is risk averse, the therapy would be different. In ulcerative colitis, the first line therapy, if it's a severe disease, would be infliximab combined with azathioprine. Thereafter, vedolizumab. Tofacitinib, if the patient cannot afford, would be the first line therapy. Ustekinumab can also be the first line therapy. Any one of them can be the first line therapy. Second line therapy would be ustekinumab or tofacitinib. Upadacitinib should be available in India in 6 months or something. Then obviously it will go to the number one places. What about patients who are risk averse? Their Vido becomes the first line therapy. Ustekinumab becomes the first line therapy. It scores over infliximab or tofacitinib. Second line therapy remains ustekinumab or ozanimab. What about Crohn's disease? If the patient is very concerned about the disease, straight away go for infliximab or adalimumab combined with azathioprine, or go for ustekinumab if the patient can also afford a higher, more costly drug. Second line drug would remain ustekinumab, and subsequently when risankizumab and upadacitinib is available, it can be used. If the patient is very risk averse, then the first line therapy for Crohn's would be ustekinumab. Then thereafter, you can use vedolizumab. Why? Because ustekinumab has a higher efficacy compared to vedolizumab in Crohn's disease, whereas in ulcerative colitis, the data for Vido is good, very good. Second line therapy, you have to go back to infliximab and adalimumab. So essentially what we're doing, I'm very fond of showing this picture. I have shown it earlier, so pardon me if I'm showing it again, but then that is actually the truth. IBD is like Ravan, the demon god with 10 heads. All we are doing is beheading one head. That's all. The head comes back. The moment we behead a head, it sprouts back. You give one anti-TNF, patient loses response, move over to vedolizumab, patient loses response, move over to tofacitinib, patient loses response, move over to ustekinumab, patient loses response. IBD doesn't go away. You need to find out what is the cure for that. You need to find out the navel shot. Till the time you don't find out the navel shot, you definitely will not be able to cure. You will only end up sequencing the therapy. I think I'll take a break out here, sir.
I think that's better. We'll take up the questions. Dr. Devendra and Dr. Ruba, please take the question. And also we'll have some poll questions now.
So I think a large number of questions have come up for you, Vineet. So there's no rest for you.
Okay,
So,
should I start? When can salvage therapy be performed after last infliximab dose in ulcerative colitis? Salvage therapy can be, I'll address it later, it can be performed anytime. If there's an indication, emergency indication, do not wait for even a minute. However, if you have a planned indication, then you can wait for 10 to 15 days. Otherwise, do not wait for a minute. Any role of adding allopurinol? No. Allopurinol you add to azathioprine. When you are giving azathioprine as a monotherapy, and there if azathioprine is not acting, there you can give allopurinol 100 milligrams and decrease the dose of azathioprine to 25 milligrams, and it has been shown to be very effective. ADA in loss of response to infliximab. Yes, I told you two scenarios, primary non-response and secondary loss of response. Please don't have a knee-jerk response. Given infliximab, no response, you can never give adalimumab. You can. If it was a secondary loss of response. If it is a primary non-response, that is you have started infliximab, induction dosing, no benefit, then no point of giving adalimumab. There you have to go out of class. But if a patient is doing very well on infliximab for 1 year and subsequently loses response, there you can easily switch over to adalimumab. You can do that. Adjunct therapy with infliximab mentioned injection methotrexate. So injection methotrexate, yes, you can give oral methotrexate, but in IBD particularly, IM or subcutaneous methotrexate has shown to be much more efficacious. So one would prefer to give once a week injectable methotrexate. Why doesn't tofacitinib act on Crohn's disease? Because what happens is the tofacitinib blocks the STAT pathway. It blocks the STAT pathways where? More in macrophages. It doesn't block the STAT pathway so well in T cells. In ulcerative colitis, the macrophages are much more important. The innate immune response is much more important. That is why tofacitinib acts. Whereas in Crohn's disease, the STAT pathway in T cells is much more active, which tofacitinib is not able to block so well. That is why tofacitinib and even filgotinib has not been found to be very useful in Crohn's disease. A recent study came out which showed failure of filgotinib, which is another JAK inhibitor in small bowel Crohn's disease. Infliximab versus vedolizumab for Crohn's disease, I think I've shown you very clearly that infliximab is superior to vedolizumab when it comes to Crohn's disease. I'll talk about vedolizumab again. I'll tell you where you can give it as a first-line therapy. Remember, when it comes to inpatients, infliximab would always score over vedolizumab. When it comes to outpatients, you can think when the inflammatory burden is not very high, there vedolizumab may act. It is a slow-acting molecule. It takes time to act. But once it acts, there's a very good retention period. Newer biologicals and IBD, I think, इससे पहले VZ were vaccine mandatory. No, if I showed you in the table, varicella antibody, if positive, do not give vaccine. Herpes zoster antibody positive, still you have to give a vaccine. That is the classical difference between the two. Varicella, if there's history of varicella available, if the varicella serology is positive, don't give varicella vaccine. Herpes zoster, amazingly, CDC says that even if the patient has had, you have to give. Neurobiologicals and IBD, that is P19, IL-23 inhibitors, which I've shown you. That is something which are the neurobiologicals. Of them, risankizumab has already been approved for Crohn's disease. Surprisingly, mirikizumab sent the data to FDA just this month or last month or something, but it has not been approved as yet. Even though TOFA has a pan-JAK effect compared to UPA, why is the response limited in CD? Because it does not act on the STAT pathway in T cells as much as it acts on the STAT pathway in macrophages. So it is not effective. 30-year-old male left-sided Crohn's colitis with complicated perianal fistula, newly diagnosed MRI showed abscess collection. Currently, I kindly advise on the right time to. So first of all, treat infection. Perianal fistulizing disease, unless until you treat infection, you should never treat inflammation. How do you treat infection? You drain the abscess. Put a ceton thread. It's a complex perianal fistula. Give antibiotics. Once you have done these three, then you start biologicals, and always add the best biological in this setting is infliximab or adalimumab, and you would like to add azathioprine. So put ceton, drain the abscess, give antibiotics. You are sure patient has started doing well, add biologicals then. Once you're sure that there's no infection. Tofacitinib role in biological experienced patients, excellent experience of tofacitinib in bio-exposed patients. As I showed you in ulcerative colitis, the data show that tofacitinib or ustekinumab perform the best if patients have had a biological failure compared to other drugs. If patient has had an anti-TNF failure, vedolizumab will not perform so well, whereas tofacitinib and ustekinumab will perform very well. Is Entyvio effective for small bowel? Yes, it is effective for small bowel Crohn's disease, but again, if the inflammatory burden is very high, there may be an issue. Are infliximab drug levels and antibody levels useful in assessing the biosimilars as well? Excellent question. I do not know the answer to this one, because this is something which has never been properly studied, because what happens is that for the same biosimilar, whether you're going to get the same drug levels or something is a little bit doubtful. Indications of biologicals in UC I showed. Again, why tofacitinib is effective in CD, I told you. Where is same question? So I've done. I think all patients. Can tofacitinib be used as an induction therapy in subset of patients in ASUC without giving steroid? Again, excellent question. So there's a clinical trial which has been. The one clinical trial has been done, I think, by DMC Ludhiana, Dr. Ajit Sood's group, and another clinical trial is ongoing at AIIMS, whereby tofacitinib has been is being studied as an induction therapy along with steroids in patients with acute severe ulcerative colitis. So without giving steroids, it has not been studied as yet. Just by giving steroids, if I correctly remember the DMC trial. So
we can ask the admin team to put some poll questions, and you can continue with your discussion. Poll questions, please. Meanwhile, it comes, you continue with your discussion.
Yeah, I think Vineet, there is a question also which is coming that what is the role in modern day in India of cyclosporin in acute severe ulcerative colitis now that so many biologics are available?
What the mind does not want to see, the eye will never see, is something they're saying something like that. So exactly like that. Cyclosporin is very cost effective. It is very efficacious drug. It is easy to give. But at the same time, as gastroenterologists, since we do not give for any other indication, so we are afraid to give it. It is actually an excellent drug. And in fact, in UK, many centers still cyclosporin is used in patients who do not respond to IV steroids, patients of acute severe ulcerative colitis. So cyclosporin is something which requires patronization. If somebody decides to patronize it, it's an excellent drug. The problem with cyclosporin, I'll tell you why people do not use. The second issue is that after 3 months, what do you do? Because after 3 months, you would like to stop cyclosporin. When you stop cyclosporin, you can put the patient on tofacitinib, you can put the patient on vedolizumab, you can put the patient on infliximab, but you would have to move over to any one of those agents, because essentially people feel that, okay, after stopping cyclosporin, you can put the patient back on azathioprine. That has been the pathway which has been thought of, but then these patients have been on azathioprine earlier, and still they got a failure, went into disease activity failure, whereby they went into developed acute severe ulcerative colitis.
Vineet, can we take up this question, please?
Yes, which of these is the fastest acting? Tofa, inflixi, upadacitinib, ustekinumab?
So can you show
All
the
three.
can you show the response?
We see the answers. Yeah.
So this is the response by the audience.
So the correct answer is number 3, upadacitinib. It has been shown to be as effective as within a day, 24 hours. So it is one of the fastest acting. Next question.
Admin next. Yeah. Vineet.
This is easy. This is an easy question. Which of these drugs can be used to treat acute severe ulcerative colitis with IV steroid failure? This is just a derivation of the half-lives which are
Yeah, anybody who has listened to the talk should be able to get it right, Vineet.
That's an application question. As you give an AIMS entrance exam, you don't give a direct question, you give an application question.
Can we go to the answers?
I think, yeah.
Show the response.
Excellent. So majority got it right. Upadacitinib is the drug which can be used to. In fact, recent data has come up with case series, again, case reports showing the benefit. Tofacitinib, we have a lot of case series, but amongst these agents, Upa is the one which has case reports which show the benefit.
Next.
Okay. Tofa 10 milligram twice a day given for 8 weeks. Patient moderate to severe ulcerative colitis. Partial response. Patient is not doing well, but not so well. What would you do? You know that giving 10 milligram twice a day is associated with more side events like thromboembolism, herpes zoster. So would you like to still continue it or change over to infliximab, vedolizumab, decrease dose of tofacitinib to 5 milligram twice a day, or add steroids?
Can we see the response?
Depends whether the patient is poor or not. What do you think, Vineet?
Yeah, that is another factor, but still, even if poor or rich, I think the people have got the right answer. That is, you continue induction dosing of 10 milligram for another 8 weeks, because that has been shown to capture response from many number of patients. So you would like to switch over to other agents if in 16 weeks you do not get a response. If the patient had no response at all at 8 weeks, you would have switched, but the patient had a partial response, so you may continue with the same.
Can we now move on to our talk? Vineet, can you share your slides and go to the talk per se now?
Vineet, you can take a sip of water before you start again.
Was my voice not coming across?
It is coming across, but
So many questions.
we understand your job.
Can you share your screen?
Okay, I'll share the screen, sir, and start again. So now, again, best second line therapy after anti-TNF failure. Again, I'm making it clear: ulcerative colitis, tofacitinib or ustekinumab. Tofacitinib is affordable, faster onset of action, but more side effects. Ustekinumab is safe but high cost. Crohn's disease, ustekinumab would be the best second line therapy after TNF failure because of efficacy of safety and cost. Right? Patient with Crohn's disease had 2 biologic failures. Should you send the patient for surgery or try the third biological? What would you do? This is a situation which many IBD centers frequently see. So there's some very interesting data which looked at 75 Crohn's disease patients who had failed 1 TNF and thereafter given Vido or ustekinumab, and 1 year data was collected. It was seen that if you 25%, 1/4 of them went for surgery, whereas 30%, almost equal number, achieved remission after third biological. So depending upon the situation, you can decide to send the patient for surgery, or you can also try another biological, even if the patient has failed 2 biologicals. What about maximizing the efficacy of vedolizumab? Vedolizumab is an excellent drug, but there are certain situations where it behaves very well. There are certain situations where it does not behave so well. So which are those situations where you would like to use vedolizumab as a first? You can also use it as a first-line biological and extract the maximum benefit out of it. It has been seen that it is more effective in biological naive UC patients rather than anti-TNF failure in UC. In ulcerative colitis patient, if the patient has mild to moderate ulcerative colitis or moderate to severe ulcerative colitis, and the patient has been on anti-TNF earlier, giving vedolizumab after that would halve the response. The response would not be that great, as opposed to the situation where if you had started the patient initially on vedolizumab. Secondly, vedolizumab persistence is significantly longer when it is given as a first-line drug. So rule of thumb is used for outpatients rather than inpatients. The effectiveness data is much more strong for ulcerative colitis rather than for Crohn's or fistulizing disease. You'll get much more benefits in patients with ulcerative colitis. If there's a loss of response, you may consider adding azathioprine. If there's a loss of response, you can also think about making it 4-weekly. The data for bio-naive ulcerative colitis for infliximab versus Vido shows that they were equal in terms of clinical remission, although infliximab was better than Vido in terms of steroid-free clinical remission and endoscopic remission, but safety signal vedolizumab was better. Can I use ustekinumab as first-line biological? Many of the patients who can afford, they feel this drug is, when you talk to them about biological, they say it is safe as well as effective. Why can't I use it as first-line biological? So for Crohn's disease, it has been shown that infliximab and ustekinumab have similar kind of efficacy as first-line biological agents. For ulcerative colitis, somewhat similar, but at the same time, infliximab still scored a little bit more in terms of steroid-free clinical remission. So again, ustekinumab is something which can be used as first-line therapy. Now we have talked about advanced therapy. Let's talk about advanced combination therapy. When we talk about ACT or advanced combination therapy, we are combining two agents. Many patients who have aggressive disease, who are refractory to therapies, who have failed 2 biological therapies, or patients of Crohn's who have had 2 surgeries, or patients of refractory perianal fistulizing disease, they are candidates for advanced combination therapy. We do not have randomized control trials available for these kind of therapy, for these combinations, but yes, these are the kind of combinations which you will do, and what you'll find, there is a common theme which emerges. The common theme which emerges is that you would not like to combine JAK inhibitor with anti-TNF agent because both of them have the highest toxicity. So you're combining 2 agents, then that will lead to a serious adverse event profile. So you would like to combine any of these agents with the 2 safer agents. That is, combine any of these agents with vedolizumab or combine any of these 2 agents with ustekinumab. And obviously the second thought process which has to be followed is that they have to have different mechanisms of action when you combine. So you would not like to combine ustekinumab with anti-IL-23 agent. So, but do you ever give up? So this is something I think we need to learn from Donald Trump. Like, this is a Donald Trump mugshot, which was there. And although he went to the jail for 20 minutes, but at the same time, everybody came up out there with a t-shirt which said never surrender. And the mugshot has become so famous. So don't be like Donald Trump in terms of going from 1, 2, 3 biologicals and a combination of biologicals in every case. Take a step back, evaluate, and think about surgery also. There have been earlier trials, which are known as lyric trials, which have looked to come up with very good data on terminal ileal Crohn's disease. But recently, a very nice paper, which was based on Denmark population, nationwide cohort, suggested something similar and more emphatically. It looked at a Danish nationwide cohort of ileocecal Crohn's disease. There were patients who had stricturing Crohn's disease also in the ileum. So patients who underwent ileocecal resection and patients who were put on anti-TNF therapy. 50% of the patients who underwent ileocecal resection, they were on no treatment after 5 years and they were doing well. The long-term adverse outcomes were much less in patients who underwent ileocecal resection. So surgery still remains an excellent choice, not only for patients with ulcerative colitis, where it is in a way curative, but even for patients with Crohn's disease, patients with stricturing Crohn's disease, patients with enteric fistulas, it remains an excellent choice, and keep that in mind. What about pre-operative washout period? You're sending the patient for surgery. So if your patient is for biological surgery to be planned, then you can give mid or late dose interval. Like if your patient is on infliximab, after 1 week, after 2 weeks, you can plan the patient for surgery, 2 to 4 weeks. If the patient is on adalimumab, 1 week later, you can plan the patient for surgery. Post-operatively, you can start 2 weeks after surgery if there are no surgical complication. Tofacitinib, you would stop 3 days pre-operatively, and you can again start 2 weeks after surgery if no complication. Emergency surgery, just go ahead. Do not think about anything, whether the patient is on biological tofa. Because what has been seen overall, there has been a low risk of complication whenever the patient has been on advanced therapy and undergone surgery. With steroids, the complication rates have been much higher. So you should be more careful if the patient is on high dose steroids. And another thing is that if the patient is undergoing surgery for ulcerative colitis, preferable to do a 3-step IPA rather than doing 2-step IPA if the patient has been on biological, because the chances of anastomotic leak are very high with 2-step IPA if the patient has been on biological. Patient of Crohn's disease undergoes surgery. What do? You look at the patient after surgery and decide what is the risk stratification. Prior colonic involvement, resection, penetrating disease, active smoking, perianal disease, previous surgery, young patient, that means higher risk. There, you would like to continue or start therapy after surgery. The therapy would consist of anti-TNF and thiopurine and or thiopurine. The patient can afford anti-TNF fine, otherwise thiopurines can be given out there. If the patient is low risk, then you can discuss with the patient, observe. You can also give out here 3 months of antibiotics out here if you start the biologicals and anti-TNF, and do a ileocolonoscopy after 6 months. If the patient has a Rutgers scoring of 0, that is no abscess ulcers at all, you can continue to watch the patient, provided the patient has been somebody with a low risk. If the patient has had a high risk, you started therapy and you just need to keep on optimizing therapy based upon the endoscopic picture you're getting. So we have talked about general principles. We have gone through various clinical scenarios. Now I'll go through some situational issues, something like rapid fire round. Is it the right time to start biologicals? How soon do you start biologicals? If you start biologicals very early in the course of disease, is it going to be very effective or not? Well, clearly this data is good for Crohn's disease, but not for ulcerative colitis. If you start anti-TNFs early, it leads to lesser surgeries, lower hospitalizations in patients with Crohn's disease, but the same kind of effect or benefit is not seen in ulcerative colitis. Shorter disease duration is associated with higher rates of response to vedolizumab, again in patients with Crohn's disease, but not ulcerative colitis. And if you look at all kinds of biologicals, you find that relationships between shorter disease duration and better outcomes was found in Crohn's disease, but not in ulcerative colitis. So early use of biologicals may provide an advantage in Crohn's disease, but this effect is not seen in patients with ulcerative colitis. Secondly, what is the endpoint of treatment? We are talking so much about what is known as treat to target strategy, or what is known as STRIDE consensus. That today we are not only looking for symptomatic response, we are also looking for symptomatic remission, normalization of CRP, normalization of fecal calprotectin, and subsequently endoscopic healing. The mucosal remission has to be there. And later on, although it is not considered as a formal target, but transmural healing and histological healing is also being thought about. So in every case, should you go for mucosal remission, that should be your target. You've started the patient on biological, patient is doing well, but you scope, you find there are still a lot of ulcers, okay, fine. Upgrade the biological or change the biological or something like, or add azathioprine. You do that in every case? Well, it seems for Crohn's, you perhaps maybe a little bit on the right path, because there is some data which is available, but there is no such data which is available for ulcerative colitis. In a recent editorial which we had written, we talked about that if STRIDE2 is the hammer, then Crohn's disease and ulcerative colitis are not the same nails. Unlike CD, progression is slower in ulcerative colitis. The surgical rates, 5-year cumulative risk of surgery is much lower in patients with ulcerative colitis compared to Crohn's disease. There's no randomized controlled trial on treat to target strategy in UC to guide treatment decision. Can you change over to biosimilar? Obviously, you will pass on the cost saving to the patient. Yes, you can clearly change. It has been shown in India, multi-center study, that adalimumab biosimilar was effective. It has also been shown that infliximab biosimilar was also very effective. These are both real-world cohort analysis, which shows that you can easily switch over from originator to a biosimilar. And many a times what happens if patient is on biosimilar, people feel they're not getting a response. They feel that they can change back to the originator molecule and that would capture the response. I think that is something hearsay, and there's no data to back that kind of strategy. Anti-TNF leads to TB reactivation. How to avoid it? So you can have a stringent screening strategy. In general, the concept has been if the patient has previous history of TB, you would never give anti-TNF. No, that is not correct. That's not the correct way to approach these patients. Clearly, if you have a very good latent TB screening strategy and you go in for chemoprophylaxis, the chances of TB reactivation are extremely low. What do we mean by stringent TB screening strategy? Do all these 4 tests: TST, IGRA, CT chest, which may be contrastina, so you can also do HRCT chest, and look for past history of TB. Any one of them is positive, clearly this patient has latent TB. And when we are talking of CT chest being positive, means that even if CT chest shows evidence of old TB, like things like calcification, pleural thickening, upper lobe fibronodular disease, go for that. And when we did this kind of stringent screening strategy, what we found that the risk reduction of TB reactivation dropped down from 17% to 1.7%, suggesting that you should have a strategy which includes MONTUS, IGRA, CT chest, and do look for past history of TB. This is one of the most important factors. And if you find this, you give chemoprophylaxis, the TB reactivation rates literally drop. What kind of latent TB regimes you would like to give? INH 9 months, INH plus rifampicin 3 months, rifampicin 4 months. If your patient has latent TB, how soon would you like to start anti-TNF? You can start after 3 weeks, but in urgent cases, you can start simultaneously. Patient is on anti-TNF therapy, develops active TB, you stop anti-TNF therapy. How long do you give antitubercular therapy in such cases? You will give anti-TNF therapy, antitubercular therapy as you give routinely. How soon would you like to start anti-TNF therapy? You would like to start after 8 weeks after starting ATT, and you find that there is a favorable response, then you can start it around 8 weeks. Is biological therapy going to be lifelong? Obviously not. So when do you stop? How do you stop? You have to look at risk. When you discontinue, you have to look at 2 factors. One is that there should be sustained remission for 6 months. The patient should be on immunomodulators. You do not stop all drugs. If you do that, the risk of relapse roughly is 40% at 1 year and 50% at 2 years. Vedolizumab and ustekinumab, we do not know the risk of relapse as yet when you stop them. What is the best predictor of disease relapse? Whether there is residual disease activity or not when you have stopped the biological. Patient has had a non-aggressive disease phenotype, and it's also shared decision making where you talk with the patient, whether the patient is happy taking a drug holiday or the patient is not happy taking a drug holiday. When you stop, first year is a chance when you get a maximum chances of relapse, so you can easily monitor the patient, and fecal calprotectin is a good way to monitor the patient. When patient has a relapse, retreatment with the same biological is safe and effective. Exit therapy is particularly not advisable for patients with pediatric Crohn's disease because Crohn's is a progressive disease, and particularly in pediatric age group, if somebody has Crohn's disease, then it may not be a good strategy to stop biological. What are the predictors of success of biological therapy? Well, there are a lot of predictors which include smoking, strict disease, longer duration of disease. You can look at inadequate drug levels, drug antibodies, hypoalbuminemia. HLA-DQ5 is one of the particular biomarkers which has been associated with non-response to anti-TNF, particularly in European population. And then there is another factor which is oncostatin M. Oncostatin M has been found to drive intestinal inflammation, and it predicts the response to TNF neutralizing therapy. What we have seen is that you cannot end up doing drug levels antibodies in many patients at times at the same time. HLA-DQ is something which you cannot do frequently in all patients. So in resource-constrained regions, what do? What is the strongest predictor of anti-TNF therapy? We found that albumin, serum albumin, both for ulcerative colitis and Crohn's disease, it's a very strong indicator in terms of indicating a loss of response. We also looked at oncostatin, which was not so useful in patients with Crohn's disease. Another important thing, if serum albumin is low, that means another adjunct strategy can be applied if you want to amplify the response of biologics, and that adjunct therapies give exclusive enteral nutrition. That has been found to be efficacious as well as tolerable. And particularly in anti-TNF refractory Crohn's disease, it has been found to be useful. So this is something which can be done. Can a short course of biologicals help? So this is a nice study from DMC Ludhiana, Dr. Sood's group, where patients of steroid refractory ulcerative colitis who were on infliximab for 3 doses and subsequently infliximab was stopped. This was a retrospective data analysis, were followed up. These patients are maintained only on azathioprine, and it was seen that 60% maintained a steroid-free remission rate at 2 years, which is a great figure, and 35% at 6 years, suggesting that if a patient cannot afford more than 3 doses, particularly in ulcerative colitis, then the patient may be maintained on azathioprine, and half of them do well. And azathioprine is one thing which we need to remember is an excellent drug. In India, particularly where we have resource constraints, azathioprine can be given for a longer duration of time and has been found to be safe and efficacious. We have data from India which shows that amongst 1,000 patients, of which 68 patients were more than 10 years of thiopurines and 250 patients more than 5 years of thiopurines, no patient developed lymphoma or non-melanoma skin cancer. Similarly, recent data again from India shows that thiopurines are effective both in ulcerative colitis and Crohn's disease. And the effectiveness at 5 and 10 years was 79% and 72% in ulcerative colitis, 68% and 61% in Crohn's disease. In other words, patients who are started on azathioprine and do well, they continue to do well. They have amazing retention rates. Like a 10-year retention rate of 61% at Crohn's disease is an excellent data. So don't be in a hurry to move over to biologicals very fast, and that too, especially in ulcerative colitis, right? Adjunct drugs along with biologicals, what to stop? Which one you can stop? 5-ASA is something which you can easily stop if the patient is in remission. Azathioprine, methotrexate, you can stop after 1 year the patient is in remission. If a patient is on tofacitinib, 5-ASA may be stopped. Azathioprine obviously has not to be given along with that. Some patients of anti-TNF develop lupus. They may present with cutaneous, they're doing well. They do cutaneous rash, inflammatory arthritis, leukopenia, thrombocytopenia, serositis, and you're confused. You feel it is tuberculosis or something which is happening. But remember, the drug-induced lupus can occur with infliximab. You look for high ANA and high anti-DS DNA titers. They will be positive. In occasional cases, antihistones are also positive. You treat them with colchicine and steroid. If there's no response, you can move over to the other out-of-class agents. That is, you'll replace anti-TNF. What about skin reactions? Anti-TNFs can also give rise to paradoxical psoriasis. Even vedolizumab and ustekinumab have been associated with paradoxical psoriasis. They can occur in 1 to 2% of cases. Treat with steroids. Again, shift out of class biological or same class biological can be given. Hepatic disease. We do have patients obviously with autoimmune hepatitis, primary sclerosing cholangitis, and they have, along with IBD. So the patient develops cirrhosis. Can you use biologicals to treat the IBD part? Well, you can use biologicals in cirrhotics. They tend to do well in compensated cirrhotics with no significant increased risk of decompensation. But remember, there's an increased risk of serious infection, and you can use a standard dosing. No reduction in dosing is required for biologicals. Hepatic
Vineet,
disease. Yes, sir.
Vineet, you have got more than 100 questions to answer.
Okay, 5
Just-
minutes, I'll wind up. So exactly 4 minutes.
Yeah.
So hepatic disease, renal disease, normal doses for all biologicals. You can use them post-liver transplant, post-renal transplant. But tofacitinib, remember, you have to avoid in child C, and 50% dose reduction is required for hepatic diseases and renal diseases. Congestive cardiac failure, recent MI stroke, patient comes with IBD and CCA, what do? Infliximab, adalimumab, contraindicated. Patient with epilepsy, avoid it. Vedolizumab is safe in these situations. Ustekinumab is safe, but again, there's a note of caution out here. Tofacitinib is clearly contraindicated. So these are two agents which are clearly contraindicated in these tricky situations. Patient has concomitant CMV, C. diff infection. Would you like to continue or stop these agents? You can continue all these agents. Tofa, somebody thought that, okay, it may promote CMV, but no, it does not. Patient with malignancy. The ECHO statement is stop TNF antagonists at least until cancer therapy is completed and possibly withhold therapy for up to 5 years after. Is that so? Well, there seems to have been a change in stance. There's an interesting study which has come up, which looked at anti-TNF therapy and also other biologicals, looked at patients who were active cancer who were taking this therapy, also patients who had recent cancer within the last 5 years, and found that both these group of biologicals had comparable safety. Choice of biological will be decided by the IBD disease activity and the oncologist. It's not that a patient has malignancy today, you have to immediately stop all the biologicals. No. Azathioprine, yes, there's a great note of caution out here, but not for biologicals. Patient is on immune checkpoint inhibitor, develops colitis. Steroids given, failed. Can you give biologicals? Yes. All these 4 agents, biologicals as well as oral small molecules, have found to be efficacious. So finally, I'll again put up this slide. This is a slide of Durga Ma, Kali Ma, and Raktbija. Raktbija was a demon, whereby whenever you try to kill the demon, even if a drop of blood fell to the floor, immediately another Raktbija would be born. So the demon never died. But again, out here, Kali Ma subsequently would cut the head, drank all the blood, drained out all the blood, and that was the end of the demon. And that is something what we are looking forward in next 2 or 3 years to happen to IBD, so that it can be, finally, the demon can be killed. So my final concluding slide is that when you're positioning therapy, look at patient is risk averse or patient has a severe disease. What affects the patient more? Talk to the patient. If the patient is risk averse or severe disease, then in ulcerative colitis, if it is risk averse, then Vido and ustekinumab are the first line therapies. If the patient has a severe disease, then infliximab is the first-line therapy. Thereafter, you can give tofacitinib or vedolizumab or ustekinumab. Again, any of them can be the first-line therapies, but infliximab has the best possible data, I would say. Second-line therapy, again, ustekinumab or tofacitinib. Second-line therapy for ulcerative colitis, which is risk-averse, will be ustekinumab. Crohn's disease, patient is risk-averse, go for ustekinumab. Patient has a severe disease, go for infliximab or adalimumab with azathioprine, or you can go for ustekinumab monotherapy. And I think that is with this, I would end my presentation. Thank you so much.
Vineet, I think you have, as Dr. Sandeep said, a huge number of questions. So I was just trying to club them up. So I think in India, cost is a major issue. So there are n number of questions on tofacitinib. So if you can just clarify quickly a few points on tofacitinib, because there are multiple questions on this. One is the Shingrix vaccine, now that it is available, when should it be given, and after how long? And if the patient is very severe, can immediately tofacitinib be started after
I showed a slide for the vaccine. I told you that recombinant herpes zoster vaccine is available. That comes by the name of Shingrix. The cost of the vaccine is somewhere around 9,000 rupees for one dose, and there are 2 doses to be given intramuscularly in the deltoid region, 0 and 2 months. It's a recombinant vaccine. It's not a live vaccine, which is also available in India. That is not so expensive. Since it's a recombinant vaccine, it can be given actually anytime, right? It is not that it is contraindicated if a patient is on advanced therapy. Now, when would you but like to give so as to get the best possible responses? Before you start tofacitinib. Let us say that within 1 or 2 months you're planning, then you would like to give Shingrix. It's not necessary that it has to be given after the age of 50. Even for 30, 40, anybody over 19 years of age, it can be given. If the patient has had previous history of varicella, previous history of herpes, any of these serologies positive, still you have to give. It is not that a patient had herpes zoster 1 year back and you say, fine, the patient would be having antibodies. No, you have to give. That's what CDC says. So that is a vaccine for tofacitinib. Otherwise, you don't have to stop at only herpes zoster
so
vaccine.
If there is an urgency, the patient has deteriorated and that's how it comes to the thing, that is the question.
It's not necessary that you have to give the vaccine in every case of tofacitinib.
No, but can it be given and tofacitinib started? Because it's a recombinant, I suppose it should be okay, right?
It should be okay, but it will not be useful immediately because the maximum cases of herpes zoster occur during the induction dosing of tofacitinib 10 milligram BD for 8 weeks. So by the time the vaccine builds up the response, the induction dosing would have passed. So it will not be very useful one. Number 2, most of the cases of herpes zoster are mild in cases of, they're not very severe in cases of tofacitinib. The patient develops herpes zoster, you stop tofacitinib and restart it after a few days. So if you can give, fine, plan and give, but it is not something like screening for latent TB, which has to be done mandatory in all patients. So it is not a mandatory.
Tofacitinib, a few other questions again clubbed and one-line answers. Multiple questions, though you have mentioned this, you have talked about it in your talk also. Why not in Crohn's disease? Why not azathioprine with tofa in unresponsive cases? And can we use tofa without latent TB testing? So these have been repeated multiple times.
So all agents, you should do latent TB testing. Tofa is also leads to reactivation of TB, so you have to do. Even vedolizumab, I would suggest do latent TB active. We recently had a case of vedolizumab with tuberculosis because India is TB endemic. So it is preferable to do latent TB testing in all, even patients on steroids and azathioprine when they started. Yesterday, I had a query from Dr. Shamsher from Mumbai that a patient was steroids and azathioprine he was starting and patient was latent TB positive. Should you give chemoprophylaxis? Yes, you should give. Again, there's a high chance of steroids.
And why not in Crohn's disease? In just one line, you have told this earlier, but again, 4 or 5 people have asked that.
That pathway gets better blocked by tofacitinib in macrophages as compared to T cells. The macrophage STAT pathway is very important for pathogenesis of ulcerative colitis, whereas T cell STAT pathway is very important for pathogenesis of Crohn's disease. So that is one of the major reasons why tofacitinib has not been found to be useful in patients with Crohn's disease. And same kind of effect has been seen with filgotinib, which is a JAK1 inhibitor, in terms of small bowel Crohn's disease, not. Whereas upadacitinib, because the other thing is that it is JAK1, JAK3, and type 2. the tofacitinib. Because of these three things, that is why this is not acting. So if it was only JAK1 selective, the chances are much more that even the T cell would get blocked. That is why upadacitinib has shown excellent data in patients with ulcerative colitis as well as Crohn's disease, and that is why it is going to become gradually going to become a chart buster the way the data has come up, and also the efficacy of oral
Dr. Desai, maybe you can.
Yeah,
Just
that-
one important question: tofacitinib in pregnancy.
not to be given, as
Yeah.
I showed you that pregnancy chart, tofacitinib is not to be given in
Not to be
pregnancy,
given.
strictly avoided. Rest all biologicals can be given in pregnancy.
Pregnancy
And
sorry.
one, sorry, so there's one gray zone, that is if a patient, this data is more for rats rather than humans as such. So often if a patient is on tofacitinib and conceives, so a scenario is, would you suggest the patient to continue with pregnancy or not? Obviously, you would stop tofacitinib. I'm not very sure about the 100% answer, but in general, experts feel that, okay, you may stop tofacitinib for sure, but you may ask the patient to continue with the pregnancy.
So Dr. Bhaskar has complimented on your excellent talk, and I agree with him. So,
Everyone agrees.
so there was some question
So I can
about
go through the
CFT.
questions quickly. Should I go through the questions quickly for 5 minutes?
Yeah.
There are 64
I'll go through
questions,
the
67.
No. See
I'll
what
go through the last.
Vineet, what
So
we'll
I
do,
think-
we have 10 minutes more, and you can quickly
Sorry?
go through the questions, and last for
Okay.
3-4 minutes we'll have poll questions. And we'll
Okay,
finish
okay.
by 1:10. Okay.
Okay, sir. I'll quickly go there. So one question is, scenario of AIH PSC overlap with UC not responding to infliximab or adalimumab. Would TOFA be an option out here? Yes, TOFA has been tried, and TOFA can be an option out here if patient is not responding to infliximab or adalimumab. We do have one patient who is on TOFA right now in such a situation. Why is Azat happened not to be given with tofacitinib, in the sense that they have, or they may probably in a way be acting almost similarly. So that would be one of the reasons. Secondly, the serious adverse event profile would also increase. It is like giving an advanced combination therapy. So that is another reason why you would not like to combine azathioprine with tofacitinib. Is finding atypical AFB in ileal ulcer and AFB staining and culture has clinical significance? Patient received AKI. Yes, there is one clinical significance out here, is that if you have non-mycobacterial TB out here, that is something which one can pursue out here, because with the normal ATT, a non-mycobacterial TB will not get resolved. Do you do TPMT regularly? No, you have to do NUDT15. Rupa and Devendra both have excellent data on this, and they've done very good work, whereby they have shown that NUDT15 is the polymorphism to be of choice. If you want to test for one polymorphism, then NUDT15 should be tested rather than TPMT in Indians. Devendra has another very interesting paper which showed that if you want 100% accuracy, then you would like to test for NUDT15 as well as TPMT, in the sense that he had one patient where TPMT was also positive. So, but first choice would be NUDT15. Bowel ultrasound.
Sorry, just one important thing. 5-ASA when patient is on biologics. So that we need to address it.
So we stop it. I showed one slide that we
Yes,
stop
yes.
if the patient is doing well on
We should
biologics.
stop it. Yes.
Bowel ultrasound gives more confidence in calling a patient for endoscopic reevaluation when biochemical factors are worsening, but disease is in. Yes, bowel ultrasound is coming up, and I'm sure Rupa is now going to say, I'm going to do a meeting in November, and she's show up a slide to come for that meeting. Why is albumin important for response of biologicals? Because biologicals move along with albumin. Albumin is a transport molecule for biologicals. So if the albumin is not there, the biological is going to get washed off. Albumin protects biologicals from getting washed off. So that is why it is very, very important. Patient in remission for 1.5 years, good response, FC normal for last 6 months, not willing to stop treatment. How long to continue and how not? I think some treatment has definitely to be given for all patients in remission, because fecal calprotectin is normal because you have given it therapy and that therapy is acting. Fecal calprotectin is not a good marker for ileal only disease. Can you suggest any other marker in this scenario? No. Fecal calprotectin is the best possible marker, but I agree it's more better marker for colonic disease and probably terminal ileal disease. The higher you go up, fecal calprotectin is not so specific. But at this moment, I don't think we have a better marker, the biomarker, than fecal calprotectin. Time to start talking about intestinal ultrasound. You find it very useful. Yes, definitely. So what to give for TB prophylaxis if a patient has history of drug-resistant TB? Excellent. Here, I would suggest that do not give a biological which is going to reactivate TB. Be very clear about it. Stay away from all those agents, because there is nothing you can do out here in terms of, in the sense we do not know the responses for when you give chemoprophylaxis in patient who had a previous history of MDR TB. Best is to stay away from those agents which can promote reactivity.
Sorry, sir. There is one interesting question. Patient has left-sided ulcerative colitis, responded well to 5-ASA. He developed azoospermia after 3 years. What are the alternative therapies?
So he is on 5-ASA.
Yes.
Right.
So you stop 5-ASA, you can't give sulfasalazine, so you can put the patient on this thing, azathioprine. Continue the patient on azathioprine. If the patient still, let us say, doesn't, but azathioprine should be fine. But these are the kind of patients, if they have increase in activity, they move over to biologicals.
Yes.
The reason being that one of the indication is not only lack of efficacy, but also intolerant to the classical pathways.
And we can check it off azoospermia after stopping 5-ASA to see whether it is the responsible cause.
Yes, definitely. Can biologicals be given for IBD in AML remission? Yes, they can be given. For liberal chemoprophylaxis, if IGRA negative but CT shows pleural thickening, you have to give chemoprophylaxis because there is evidence of old TB if CT shows pleural thickening. Any studies of TOFA and Crohn's disease, there's some real world evidence. The phase 3 trial did not show any benefit, but there is real world evidence which showed that TOFA and some CD patients will work. I suspect that if colonic CD is there, tofacitinib may work in a real world situation at times. So if there is no choice, you can try it. Is there a term called as acute severe Crohn's disease? No, there is no term, Dr. Patil, but you can think about working on it. It's not a bad idea. Severe Crohn's colitis, you can think about. It's not a. When to stop advanced therapy, biological or tofacitinib after ASUC? Okay, interesting question from Satantra that if a patient is, can you, the question, the principles remain the same. One is that it is an aggressive disease, so chances of relapse would be higher. Yet at the same time, if you want to stop, you can stop after 1 or 2 years when the patient is in complete remission and the fecal calprotectin levels are normal, or you've done a colonoscopy, sigmoidoscopy, which is normal. Role of metronidazole in post-op Crohn's disease. First 3 months, you can give metronidazole plus ofloxacin. It has been found to be effective in the initial 3 months, and thereafter you can decide whether you want to switch over to a biological or not. Role of FMT in IBD, it is under trial phases. There are 5 or 6 meta-analysis available which have shown that. Sir?
Can we have the poll questions in between?
Okay.
Yeah. And then we have the question answer again. So technical staff to actually pose the question.
Meanwhile, the questions come, you can continue with the discussion.
Yeah, you continue till the time it comes. You will continue answering questions.
Okay.
Yeah.
ये तो हो गया था, sir. This we had done. Next question.
Next question.
So this is an interesting question. If whoever answers it would be, I would say, an expert IBD doctor. A patient with Crohn's disease was started on induction dosing of ustekinumab, the initial induction dosing. After 4 weeks, there was minimal response. What steps can be taken to optimize therapy? Stop ustekinumab and replace with adalimumab. Observe for another 4 weeks. Give another induction dose IV at 4 weeks. Add steroids. This is what I call a distinction question. वो prof में होता था ना sir कि एक D question होता था. ये D question.
This you have already answered in your talk?
No, I haven't done.
None of the questions he has discussed.
Yeah.
Anyway.
So, okay, 1/3 of the people, 40% did get it right. That's excellent. So, give another induction dosing. That would be, in a way, partially the best answer. Observe for another 4 weeks is also fine. Both the answers are correct, but recent data has come up which has shown that if you give 2 induction dosing, and particularly in this group of patients who are not responding very well initially, you may be able to capture the response.
Next. Yeah.
Recombinant herpes zoster vaccine is given in all these situations except recent attack of herpes zoster, aged more than 65 years, has received varicella injection adolescent. All those who are listening to discussion should immediately crack this question.
Shows the audience response.
My God. Okay, so adolescence is the correct answer. As we had discussed, recent attack of herpes zoster, age more than 65 years, even if they have received varicella injection, you would like to give them these are the CDC recommendations. Okay.
Okay, I think move to the next questions.
We still need to do, sir.
No, no, how many questions you had?
There is no other questions. Okay, I think go back to your question answer session.
Another
So-
5 minutes we have for question answers. We have
Moderate
extended
juice.
for 15.
Moderate
Yeah.
UC patient developed azoran-induced pancreatitis. What is the next step, sir? Next step is you can't give azoran. You can also not give 6-MP. So you can start the patient on tofacitinib or you can start the patient on biological. And what should be the next biological? Biological, as I have told you, ulcerative colitis. Here, pancreatitis doesn't mean that the patient is risk averse or something. So the choices remain the same. If the patient, you can give infliximab, you can give tofacitinib, you can give vedolizumab. If the patient wants to take ustekinumab, can also take, but provided the patient requires it. If the patient is doing well on 5-ASA, you can continue the patient on 5-ASA. How to counsel for elemental and semi-elemental diet in Indian setting? Well, that requires, I think, in a way, you have to tell them the advantages of this diet, and particularly in Crohn's disease, sarcopenia is very important. If the patient has sarcopenia, the chances of response are very less if the patient has sarcopenia, low serum albumin, etc. So I think that is what. Second is that it is expensive, but not too expensive also. If you take in bulk, I think it comes down to 500 or 600 rupees a day. So at the same time, it has an anti-inflammatory effect besides providing the nutritional benefit also. So these are things which you can talk about. Can we combine elemental diet with biologicals? Any trial? So yes, there is no trial which is there, but there are case series which are available. I showed you 2 pieces of data, one from Ludhiana, one from AIIMS, which showed EN along with other agents and the benefit of EN along with other agents. Otherwise, the trials are more with the elemental Crohn's disease exclusion diet trials are there, exclusive CDD trials are there. Need to know the role of budesonide in CD today. Yes, budesonide is excellent for mild to moderate ulcerative colitis, where you don't want to give systemic corticosteroids. Similarly, in Crohn's disease, mild Crohn's disease, budesonide can be useful. So there are 2 budesonide preparations available. One is a controlled release preparation, which gets released in the ileum, somewhere in the proximal distal ileum. So that would be useful in that setting. And one another is MMX preparation, which would be useful only in a colonic disease setting. Role of AI in choosing biological. I think right now, yeah, I agree that chess is being played by AI. So very soon, I think we'll be looking at AI in biological in recent future. We might be looking at it, and considering the number of agents which are coming up, it may be important also to have that. Can we step down biologicals after remission? Yes, we can step down after 1 year of remission. Experience of tofacitinib as rescue therapy in ASUC compared to cyclosporin and infliximab. There's no head-to-head trial, but yes, it is effective. Probably as effective or slightly less effective, can't say, but it is effective. When should we start infliximab in whom latent TB is found positive? Start chemoprophylaxis within 3 to 4 weeks. After that, you can start. If very urgent, you can start simultaneously. In indeterminate colitis with secondary non-response to adalimumab, can we try tofacitinib? Yes, it's a good indication. You can try it out. Can we combine biologicals with tofacitinib? Yes, you can combine vedolizumab with tofacitinib. You can combine ustekinumab with tofacitinib. You can combine risankizumab with tofacitinib. Do not combine anti-TNF with tofacitinib, because then the adverse events may be much more than you can manage. How do you reassess disease activity after induction therapy for UC and CD? You can assess by symptomatic control. You can assess by fecal calprotectin. In case it's a small bowel Crohn's disease, then you may have to do imaging, and otherwise you can do a sigmoidoscopy in case of ulcerative colitis. Should we take lean body weight while calculating the dose of azathioprine? I don't know the correct answer to this, but I think we take the total body weight, the general regular body weight, not the lean body weight. Early intervention with Crohn's disease, yes, helpful, particularly because Crohn's is an aggressive disease. And the moment you find that it's an aggressive cause, early intervention is very useful. And as I showed you, early initiation of biologicals is useful in patients with Crohn's disease. TOFA and ASUC without ruling out LTB, how safe it is? It is effective. Safety, thrombosis can occur. Coronary artery disease, sudden deaths can occur. So give them thromboprophylaxis. Herpes zoster can occur. So you have to be very careful about TOFA. Methotrexate adjunct can be given with adalimumab. Also for patient had partial response UC with adalimumab. Yes, methotrexate can be given to patient with adalimumab. Safest biological in pregnancy for mild to moderate ulcer. That biological is not available in India. That is certolizumab. That is the safest biological. Otherwise, most data is there for infliximab and adalimumab. Vedolizumab and ustekinumab also data is coming up. So you can give ustekinumab or vedolizumab if you want to look at safest biological today. But most of the patients of UC get dependent on steroids or intolerant to AT. What is the role of TOFA in CRUC? So if they're intolerant to AC, you can move over to TOFA clearly. Should azathioprine be always added with biologicals? Yes. Infliximab monotherapy is less effective than infliximab plus azathioprine. There is clear-cut evidence on that. You have to add. Even with adalimumab, I would suggest that you add. And as I showed you, there is data emerging that with vedolizumab and ustekinumab also, in patients with Crohn's disease, you can consider adding azathioprine, or whenever there's a loss of response, you can consider adding azathioprine. If ustekinumab started as first line and fails, will anti-TNF work? Yes, they will work because they have different mechanisms of action. And in fact, what happens with, there's a very interesting question asked by Shrikant Gopi because from Hyderabad, because in the sense that what happens is that when you give anti-TNF initially, it exhausts all the anti-TNF. As a result, the immune responses move towards TH17 pathway. So you have a lot of IL-23 which comes up, which is apoptosis resistant. So actually, when you give ustekinumab, at that time, it works very beautifully. When the disease is very early on in the disease, the TNF pathway is much more effective than IL-23 pathway. So it works as first line excellently, but theoretically, anti-TNF may work a little bit better.
So I think we
Yeah, we have to stop. Actually, there's so many
Yeah.
questions you
yeah,
can work the whole day long. I think you look tireless, but the time is a concern.
I just want to read out one question that has come to you, and multiple such, and that is, you are awesome, and this was an unmatched talk.
And this is not a question, actually.
Yes, in the question box that has come.
I think there was an interesting question by Dr. Jayanti regarding what is the role of artificial intelligence.
I answered that, sir. I answered that. That's a very interesting question. In the sense that you are looking at AI certain things, and time will come that you'll be looking at AI for biology.
So we can we call upon Dr. Sandeep Nichavan for
Yeah.
his final comments?
Yeah. Actually, and there are two comments I want to make. One is excellent moderation by Rupa and Devender. And as far as Vineet is concerned, he is master of rapid fire questions. And he is number one in chess master in IBD. So you have played the chess, but once you know the subject, you know the agents, how to go along with them, then you can play chess. Thank you, Vineet. Thanks for your excellent talk.
Thank you. Thank you, sir, for giving me the opportunity. Thank you so much.
Yeah, thank you.
It was
Matthew.
wonderful, and moderators did a wonderful job. Active participation, huge number of participants. We have participants across India, from outside India, from Malaysia, from Gulf countries. There's so many. And I'm sure this program of IST Masterclass is gaining real importance and is doing extremely well. And many sessions have, all the sessions you look at, number of participants extremely well. And we have the next session on alcohol-related liver disease, which will happen on September 10th. And I request all the participants to register early enough whenever you get the link, and you can even post your questions on the day or on day prior to that. So thank you so much, and thank you, Vineet, once again, and thank the moderators once, and especially Dr. Devender Desai and Dr. Ruba Banji for active participation and moderation. And I would like to thank the admin team for this excellent arranging excellent platform, and also a silent person, Nisha, who is our secretary in our office work, and she is doing an excellent work. Thank you, and she was coordinating everything. And I thank governing council members of ISC for doing everything on the background work. Thanks a lot. I think you had to say bye. We'll see you all.
Thank you, Dr. Devendra Rupa. Thank you. Thank you, sir.
Thanks. Thank you very much.
Ruba and Devender, thanks a lot.
Thank you. Thank you, everyone.
Thank you.